I have a couple of questions that actually are related to each other that I want to pose to each of you based on comments that you made. You'll hear them start to focus on the same subjects, but coming at it from a slightly different angle, in part taking off from comments that you yourselves made. So, Kate, you mentioned that there are impediments to achieving the CMS goals and not wanting to get you in trouble with the Congress or anything, but can you share some of what you think are the major impediments to achieving these CMS goals? And then the second issue I'd like you to address is you talked about the goal of reducing administration or administrative burden, and that's presumably not the impediments on CMS doing what it does, but more the burdens that CMS may be imposing, or a CMS and Congress together on the actual practice. So if you could try and take this on.
Sure. I do think that in terms of being able to ultimately achieve the goals of better health for populations, better care for patients, lower costs, we do still believe in those things at CMS, absolutely. Again, I think goes to, at least when you think about the macro legislation, there are some requirements within that legislation that I think make it a little bit more challenging to be able to, again, sort of meet providers where they are, given, again, the requirements in the legislation, but I would say also some of the ways in which we have implemented the program. I do also think that, I'm actually, like you, I'm fairly optimistic about the future about this. Having said what all of the challenges are to the implementation of these programs, I think there is a great will and desire to be able to transform practices and get away from the fee-for-service system that I think a lot of people sort of feel oppressed under in some ways in terms of the way it makes them practice medicine. So I am actually fairly optimistic that we can get there, but that it is going to take a fair amount of time. And so I do think that the ability to have a bit of a slower on-ramp, particularly for providers who need more sort of upfront assistance to be able to transform, would be a helpful thing to have, in particular thinking about it under the macro program. I also think that the burden is a major impediment. And there's a lot of burdens out there for clinicians and other types of providers, some of which are imposed by the requirements under MACRA, but not entirely. And so I do think that that can be a significant impediment to the program. We are taking a very comprehensive view around reduction of administrative burden. Really, we started that because of MACRA and recognizing some very real, some perceived, burdens related to participation in that program. But we're really actually looking at it very holistically, including thinking about things like documentation. What should the documentation requirements be when you've moved away from fee-for-service into population-based payment arrangements? You probably don't need to document in the same way and the same kinds of things under those kinds of arrangements. It really should be about the quality of care that you're providing for your patients. So starting to think about that. There's a lot of low-hanging fruit of things that we can do, not even necessarily through regulation, although I think some would be through regulation, that we think can make significant differences in the lives of a practicing clinician through some of our sub-regulatory mechanisms. So, I would say, the variation in practice and trying to meet people where they are and our ability to do that, or our inability to do that, I think in some of the ways that we think would be more impactful is one barrier. The other, though, is really around the administrative burden and clinicians feeling like, you're asking me to transform practice. All these payers are asking me to transform how I practice, and yet I'm still, at least partially, under the fee-for-service system where there are a great many burdens related to documentation and use of EHRs and so forth, and I can't do it all. So I think those are some of the tensions that we think are out there and we're trying to work through.
Great. I have some more questions since your comments, but I want to pose a couple questions to each of the others. Bill, you talked about the clinical metrics as being an unfulfilled promise, which I strongly agree with. The proliferation has seemed to me to be probably the most burdensome and unhelpful aspect, but it may be they're just not as good as we would like to see them. What would you suggest that could usefully be done through either NQF or any other kind of organization, or the NCQA model, or any that comes to mind that either from your time in government or associated outside of government that you think would make a difference here, since this seems to be a linchpin of a lot of the administrative burden and frustration?
Yeah, I mean, ultimately, you're talking about practice variation. And, you know, when back in the day, which is about 2000, 2001, crossing the Kali chasm, I can still quote that, and students look at you now, oh, what book is that? You know? Yeah, I know, but there was a notion that metrics would be used for accountability and move the mean and shift the curves. I'm not sure you need to necessarily think of it that way. So, you know, NQF, as again, I'm a NQF veteran, have hundreds of measures. Only a tiny number of them are used. NCQA often didn't have pharmacy data used because the plans didn't have it. So if the plans couldn't use the metrics, they didn't create the measure, which is a problem. I was on PCPI for 10, 15 years, and that has its issues. I think you need the payers to have uniform metrics in a community, which is what we've done in Arkansas. So you have everybody try to get the same measures. I think if you can get data measures out of EHRs, then you could have all payer data collection and reward based on that. The problem is the EHRs can't do it yet. And I have data on that. I've just had conference calls with ONC and CMS, which has a real Achilles heel for CPC Plus. So, you know, you kind of do your own. There are some measures that are important. So we put a pay-for-performance program separate for early elective deliveries using the Joint Commission measure. And within 3 years, we dropped early elective deliveries in Arkansas by 95%. Okay? And I now have birth certificate data that shows we now have 3,000 fewer deliveries per year in Arkansas before 37 weeks. Well, that's on a base of 35,000 deliveries. That's just one measure. So, you know, measures are useful, but you got to use them, you know, kind of in a targeted way. One of my favorite measures right now is percentage of your primary care medical home patients on chronic Xanax. Well, you're not going to find that in the NQF, but it's an interesting curve. And you go after the tail. And you say, hey, guys, do you know, look at you compared to here, and guess what? If you need to start setting, you just start cutting the curve off. We did that with antibiotic prescribing for the common cold. Don Berwick got excited when he said we had an episode on common cold. We reduced antibiotic prescribing for URIs by 25% in the first 3 years of our episode. We moved it from 50% of people getting antibiotics to 33%. And now we're using that metric for the outliers to cut the curve off, saying if you have more than 60% of your common colds getting antibiotics, you miss that metric and you might not get your bonus money. So there are different ways of doing it, but you don't need a national board to come up with a measure to go after antibiotics for common colds or Xanax.
But don't you need some kind of national or volunteer agreement so that everybody comes up with the same set of metrics, unless you think there's some reason? I mean, it seems to me some of the obvious ones are either, as you defined it, the percent of, or the number of babies that are born before 35 weeks, or the percent of deliveries that are done vaginally as opposed other strategies or other metrics?
Hypertension control, diabetes control, which CPC Plus is now
Yeah.
emphasizing. Sure.
Yeah, so, okay. I guess I'm not sure then why the pessimistic attitude toward that you could actually take what seem to be hundreds of metrics and get some agreement about actually the ones for primary care.
I'm optimistic, but I'm pessimistic about the enterprise. And I mean, the collection of large numbers of measures, but I think focused and very targeted measures are a very effective use.
Okay. Sam, what was you had commented that some of the biggest barriers were around moving care upstream, and some of the efforts that you've been doing to try to move care upstream. But along with that, I'm going to ask you to take this on, but it's a question that comes to mind definitely for CMS. I don't know Arkansas as well, so I'm not sure whether it's as relevant. And that is the concern that I've had when people talk about having a program payment variable or at risk. Usually they're talking about a very small part of that payment that's actually in any way related to value or outcomes or quality or anything other than having done the activity. I keep feeling frustrated that we're fooling ourselves, that we think we have much more payment at risk than we actually have payment at risk. If you have a part of an update at risk in some way, but 98 or 94% of the payment is fixed, the base payment, should we believe that really is enough? Maybe for institutions, definitely not for clinicians. We know it takes a lot more to move the dial for physicians than the tip of the tail of the dog that we're trying to wag here on it. So,
right.
And if you would, and then Kate, maybe a word, and then I'm going to open it up.
No, I think that's a great, insightful question. So let me paraphrase it. There's been a lot of attention paid to what is the amount of total medical spend that is associated with some kind of incentive, whether it's APM or MIPS or our value-based payment at United Healthcare. And we've been searching to try, in the private sector, trying to find out what is that sweet spot. And there's been very little discussion of what is the incentive at risk within that total payment. So you saw the Harvey Ball where we say right now, 2017, we have $61 billion of medical spend associated with value-based payment. Within that 61 billion, we have, about 15 billion, well, 14 or so billion, maybe 25% associated with an incentive. But not all of that is being paid out. We would love to pay 100% of the incentive because we know if we paid out the way we structure our contracts, if we paid out 100% of that incentive, say 14 billion, we would have much lower discretionary utilization of ERs and hospitals, as well as care for the hotspotters and so forth. But we're not close to it. So what is the percentage that we're paying out? And then of that percentage, what's the sweet spot to actually change behavior? I don't have the answer to that yet. I know when CMS introduced their value-based payment to hospitals, 2% moved the curve. So what we want to do is get to 2% with physicians and with delivery systems, and then work from there to see where we can calibrate what's going to be the tipping point where we really do move the needle. Well, so it's unknown. Yeah. And that's where we need public-private partnerships with CMMI and with Arkansas Medicaid. And you have to get us a contract, first of all, to get into Arkansas Medicaid, by the way, Bill.
We don't have managed care.
I know. You're doing it so well without managed care. Anyway, my point is, I don't know the answer. I don't think it's going to take 10%. because like I said, we're moving the needle now, but it's gotta be more than the single digit. I mean, 1 or 2%, low single digit.
Well, you certainly don't need 10% to move the hospitals. I mean, I was astounded when CMS started paying for the reporting of quality metrics. The number of hospitals that, as I recall, it's now a bunch of years ago, I think it went from about 40-something% to 90% with a very small payment. So hospitals, probably because their margins tend to be so low, tend to move easily. I don't know there's much indication that 5 to 10% payment moves most clinicians.
Yeah. So what I'll say about that is you're right. So now we're like at 98, 99% of hospitals report just for pay for reporting. So that is absolutely true. I think for physicians, what we've actually seen in the, what we now call the legacy programs, so we don't have to say meaningful use anymore, or PQRS, is in the last year of the PQRS program is 72% of clinicians reported. So that was, a huge jump from just 2 or 3 years previously where it was about 25, 28%. And that was because there was, that's PQRS switched from an incentive program to a downside program, a penalty program, right? So that's clearly what drove that.
I know those work.
Yeah, exactly. So, I think this is something we think about a lot in CMS and what research is out there seems to suggest that for clinicians, it needs to be higher percentages. I think the challenges there are exactly the tensions that I spoke about before, where you may have a large group practice or a health system that can have, put forward the upfront investment to be able to take on more risk, either just through a CMS program or ideally through a multi-payer program, whereas that is much more challenging for the smaller practices to be able to make those upfront investments and feel like they can even take on 2 or 3% risk.
Great. Yeah.
So I would say that we have we have a toll booth for quality payments, and so you don't get nickeled and dimed for hitting different metrics. So you have to pass a basket of metrics, which I think changes behavior. We only have like a $5 PMPM, and we have had no problems getting people to sign up for practice transformation. But we offer a 50% shared savings to primary care at a targeted number. That got their attention. So people will take a small PMPM for a bigger target, potentially reward. I think the key thing in incentives, and I'll be quiet, is that, and one of the flaws of some of the programs, you want to make sure the early adopters have winners. If you burn out or you shortchange early adopters, you'll never get the mainstream. And you really want to make sure you have some winners in the program.
Thanks. Good way to end this part of the discussion. I'd like to take the time we have remaining and open it up to questions from the audience. Yes.
Hi, I'm a physician at an academic center in New York, and I'm wondering what your thoughts are about incentivizing providers to adopt team-based models, because when they're working by themselves, they burn out, as opposed to, on the other hand, they also have very few disincentives, I think, to use expensive technologies. So doctors like fun, expensive new toys, but they'll prescribe a $100,000 genetic test or a $100,000 cholesterol injection, but they won't employ that extra advanced practice provider in their practice that could really help patients and help them hit metrics, et cetera. So what can we do to disincentivize the use of expensive toys and incentivize the adoption of team-based models?
So in the primary care medical home model with the 50% threshold, we've had practices in CPC redesign what they do. Pat Conway used to go around talking about the SAMA Clinic in El Dorado, Arkansas, which many of you could never find on a map, but it's on the Louisiana-Arkansas border, really in the middle of nowhere. Totally redesigned their practice, created teams. When you start doing a population-based approach, people start changing their team dynamics, and it's been very impressive.
So basically responding to the different incentives?
Exactly.
Correct.
Yes.
Sam, anything else? Yeah.
It's been really interesting to me when you talk about a line for incentives, and it's, some of the slow up-ramp, I think, is due to a basic lack of knowledge in your rural areas. The AMA just passed this summer, I guess, yeah, last summer, a couple weeks ago, a resolution that wanted basic public health knowledge and teaching to their rural physicians. My point being that a lot of what you talk about is basic public health, the population health, ways that until recently physicians were not trained to think about. I'm wondering, as you put all this money into creating incentives to get physicians to work better, and I just might not know, I'd like to see some of that money put into education and skills building, because one of the reasons you may not see a change in behavior, especially at the physician level, is they may not have a good knowledge base. In order to learn the things that you're talking about can be a pretty big swing. When I was in medical school, I'm a lot older than I look, they gave me a book on epidemiology and biostatistics. That was my entire public health education at where I went. I am a public health physician, so I went on to do extra training. But for the busy physician in a practice in a rural area, in a small practice, nobody pays or actually supports them financially to learn this massive new amount of knowledge that it takes to adapt to these new payment systems. And they may not be able to do that. And I haven't seen, you pay on the end of improving measures, but it seems like there's not much in terms of skills building to meet those new measures. So just your comments.
So I was at the AMA meeting, and I know the resolution, and I'm not nearly as pessimistic as that resolution. We've coached our practices. We have sent people out. The problem that small rural practices have had is that the payment system has required them to do very quick, high-volume visits. They've been doing sprained ankles and colds because the profit margin on a sprained ankle and a cold is much higher than that for diabetes and hypertension. You can see 3 colds in 15 minutes. We can only see 1 diabetic hypertensive heart failure patient. It's a payment problem. We've implemented population-based approaches. We've had coaching in Arkansas. Most of our practices are rural, small, onesie-twosies, and they've done just fine.
I just want to add to that. It's a really insightful question. First of all, the payment counts. That's why it's the top of our integrated value strategy. Without payment, online payment incentives, you're not going to get them to change behavior. On the other hand, once there is payment incentives to look at population health, even small practices are interested in the data we provide them about who are the hotspotters. They know they have to change, if they're going to get any shared savings, much less shared risk or capitation down the road, they have to do better at managing care for the people who are most vulnerable. And that's inherently a public health phenomenon. And so they teach themselves. But so the first thing is that we have a lot of data. United Healthcare, we believe in this partnership with physicians because we don't deliver care. They're in the 4 walls and they don't have the data. So we provide the data to say who are their hotspotters, who are their frequent ER utilizers, who are the patients who have not been seen by an attending physician within 7 days post-discharge, who are the ones coming from SNF or acute rehab that are oftentimes lost through the cracks. And that type of continuity between our data and their care management is very powerful. Second thing, there's an IT solution here because we're investing in a population health platform, which is an entire end-to-end service application. We would love the EMRs to engage and participate, but we're not going to wait for that because that may be waiting for Godot. We just want to keep this real-time decision support with the physicians so that they know that which are public health issues, which are social determinant issues, which are prescription issues, adherence issues, formulary issues, so that they can make decisions at the point of care more rational.
Yeah, we have time at least for one more.
Yes. Hi, my name is Shubha Bhatt. I'm a primary care physician at a primary care startup in Philadelphia focused on Medicare Advantage and managed Medicaid populations. I have a question for Dr. Goodrich, which is that you had talked about the challenges of the documentation requirements in non-fee-for-service work. And it's something that I struggle with every day, is that, you know, we're in a different payment model, and there's very specific things that we want to communicate for our teams that are important, but then it still feels like we're in the fee-for-service world through just the EMR documentation. And I'm hoping that you can speak a little bit more about that.
Yeah, you know, I think when you're in an arrangement that may be not entirely based on fee-for-service, but where a claim is still triggered, and so there is still a fee-for-service component to it, you know, the same documentation requirements are still in place. I would say these are, there's, in my view, and maybe I'm not totally understanding the problem, this is not really so much an EMR issue. It's a CMS documentation requirement issue that is manifested through EHRs, because we use EHRs now and not paper, right? So they really actually, I think, are essentially the same issues. So like I said, this is something that we are undertaking quite a bit of work within the agency to think about how we can modify the documentation requirements to, again, I think, bite off a lot of low-hanging fruit of ridiculous stuff that's just not needed anymore. But then on a much larger scale than that is take a much more comprehensive, holistic look at documentation requirements in the new payment environment. That is not going to be quick. I want to just warn everybody. That is not going to happen overnight. It is going to require, I think, a lot of very close, meaningful engagement with clinicians to understand what is most meaningful that we can and what we can actually impact. One of the tensions that we're always working with, by the way, with documentation, just to say out loud, is the tensions related to fraud, waste, and abuse, right? Mm-hmm. So program integrity. So we also have to keep that in mind, and those are going to be considerations going forward. But I do want to at least have you hear that we understand that this is an area that needs a lot of attention and really needs, I think, a rethinking. And so we are starting to do that.
Do we have time to one? Are we done? No. My timekeeper over there tells me that we are done. We do have 10 minutes, I think, before the next session starts. Is that correct? Or we go right on?
We all agree with each other, basically.
Straight on. Oh, okay. We will have a changing of the guard then. Thank you very much.